All right, hello everybody. This is Mrs. Ignacio and Mrs. St. Martin. We're doing a tutoring session for Nursing 101 Health Assessment. And first things first, we wanted to show you the resources to make sure you know how to access them. So log on to Evolve and go to your textbook, which is the 7th edition. You're going to click on that. And then you're going to go to student resources. And this may be something you already know, but I just want to make sure that everybody knows how to access the resources. So for the sake of what we're doing today, we'll talk about chapter 10.
Mm-hmm.
Okay. And then you go to key points. And so these key points, I would advise, it's going to come up as a Word document. I would advise that if you don't read the textbook, but I do recommend you reading the textbook before going to class, right, with your classroom instructor, is to print out these key points. And during your classroom instruction, you should be going over this, right? And you should actually have questions. So I would advise coming to your classroom instructor with questions after reading these key points. And guess what? This is only about a page and a quarter, right? So definitely everyone should be able to print it out for the chapters that you're going over in class. And those key points are wrapping up all of the meat that you need from the particular chapter. So let's take a look at these key points for a moment. So this is chapter 10, head, eyes, ears, nose, and throat. And I believe this is going to be on your exam coming up. So, and we kind of talked about it in lab last night. So sensory perception is important. So we think of our sight, hearing, smell, taste, touch, all of those 5 senses. To link that to the cranial nerves, right? We talked about last night that the cranial nerves are important because they are bringing that information from your 5 senses to the brain, right, for interpretation. So continuing on, and actually this might be a good point to get in my plug for the cranial nerve funny face guy. So let me bring up that guy. Okay, so this was the initial drawing that we looked at talking about the cranial nerves, right? And so if you're able to reproduce this particular drawing when you have a test, this is going to help you remember those cranial nerves because you could very well have a test question about the cranial nerves. So each of these particular numbers represents a cranial nerve. So this is one thing that you could practice drawing. And let's go to the muscle guy, the cranial nerve muscle guy. So I like this guy because he has all of the nerves already labeled, okay? So each of these particular cranial nerves, there's 12 of them, is responsible for a particular function. So when we think about, and we're going to do this next week in lab, we're going to actually do a neurological focused assessment, and we're going to actually work through assessing each of these cranial nerves. But this is something that you should be familiar with in the classroom as well, right, for your tests and for your classroom discussions. So each of these represents your cranial nerves, each of these in the drawings. Okay, so let me go back to the notes because I just want to kind of do a run through. And so this tells us a key point when we are doing our health assessment of the head. Okay, it's a bony structure, protects the brain, right? And we know that going back to anatomy. Please, nurses, don't forget your anatomy. That's going to be essential to be successful as a nurse. Okay, so we think about the external structures, right, are the eyes, the eyebrows, the upper eyelids, the lower eyelids, eyelashes, the conjunctivae, which is when we look right in the lower lids of the eyes, looking at that, it should be pink and moist, not red, right, because then we think pink eye. The lacrimal glands, that's what actually is secreting tears, right? So all of these things are what we're examining when we are looking at our patient, when we're talking about head, eyes, nose, and throat, right? So there's 3 layers that surround the globe of the eye. The sclera is the white part of the eye, and we talked about an abnormality, right, an abnormal finding, which was scleral icterus, right? And that could be found in our patients that have jaundice. That's a liver patient, right? So understanding what's normal and then When there's deviations from the normal finding, what does that abnormality mean? Okay, so the inner layer of the eyeball is the uvea. Then there's all of those things that you learned in anatomy, right? And I'm going to continue. And if you don't remember any of these terms, take a break, go to YouTube, look up a quick, video on show me an animation of how the eye works, so you can kind of refresh yourself, because that's important to understand. All right, so now we're talking about the rods and cones of the eye. That's important, right? So when you're reading in a chapter, the rods and cones, which one is for light, which one is for dark vision, right? And how would the patient be presenting if they had issues with rods and cones? Now we're jumping to the ear, right? And last night in class, all of you had the opportunity to look inside of the ear, and we may have seen some cerumen. That's a normal finding, right? Now, yes, and so we talked about the external ear, right? And we know that the middle ear, this is from anatomy as well, right, is responsible for sound amplification. And so we think of the eardrum. And so a good thing to do, and we'll probably do this in lab, is look at what a normal eardrum is supposed to look like, because that could very well be a test question. What would you do if you had a case study and the patient presented, and upon examination of the ear, it did not look pearly gray, it was red and inflamed? Well, I would be thinking otitis media, right? I would be thinking that they have an ear infection. So that's how you have to think as you're reading through this. Okay, the next thing that's talking about is inspired air. So air that comes in through our nose. So last night we talked about inspecting the patient's nose, asking if they had any history of rhinoplasty, have they nose surgery, right? Have they had a deviated septum? Maybe their nose was broken. Maybe they play sports or boxing or something, and their nose was damaged. Do they have a history of sinus infections? So all of that is going to affect, how you assess your patient. So moving on to the mouth, the lips, the teeth, the gums, the salivary glands, right? Looking at that oral mucosa. Do they have circumoral cyanosis? Are their lips blue, right? So looking at their teeth, because if they have missing teeth, loose teeth, poorly fitting dentures, that's all going to affect their nutritional status, right? So, and I think so. Those are all things that we need to assess when we are looking at the face, the head, the eyes, the mouth. Continuing down, we will ask the patient to go, right? So you can see their uvula. And something that you might find on an abnormal finding, if the patient is complaining, I feel like I have a sore throat, you might find, that the back of their throat may be red and inflamed, and then they may have white spots. Shamika, what do you think if the patient presented in that way, and then you saw the white spots upon assessment? What condition you think the patient may have?
The dehydration.
Dehydration possibly, but if you were to examine my neck and I said that it hurts to swallow.
I'm sorry. I heard you wrong. One more
Okay,
time.
so I have difficulty swallowing. You assess me. I go and you see that it's red and inflamed, and there's white patches.
Oh,
And the
yes. Maybe strep throat.
strep throat, right? So you, right, as nurses, and Shamika, you're the representative for the whole class, right? So you should be able to understand that. And in your nursing mind, now that I have done that assessment, okay, this means that this patient is going to need a rapid strep test. They're probably going to get antibiotics. I better verify, okay, that they're not allergic to penicillin or any, and especially any antibiotics, because I know that that's going to be the course of treatment. So when you get this case study, right, because NCLEX is going to give you these case studies, this is how you should be thinking critically, right? So I know that this is a health assessment class, but you want to think, okay, well, what comes next when I find this abnormal finding? And that's going to be helpful, I think, as you answer the questions that are next generation questions. Okay, moving on, we have the sternocleidomastoid muscle, the trapezius muscles, right? So those are responsible for movement, and that's what we did last night. We assessed, right? Put your hands on the patient's shoulder and shrug their shoulder. Also, to resist my hand, right, on your face. So That's linking what we're doing in lab, what you're seeing for the classroom. Now the larynx, right? That's going to be your vocal cords, right?
Yes.
Along with your trachea, and so that's going to allow for sound. Okay, and last night we tested for the thyroid as we gently put our fingertips and we stood behind the patient and we swallowed, right? So that's thinking, okay, are there any abnormalities there? And we're always looking for bilateral symmetry, okay? The other thing that we looked at was JVD, and what is the angle that the bed has to be at when we're assessing our patient for JVD, Shamikwa?
The head of bed has to be elevated.
Yes, what is the degrees? I'm looking for a specific number.
Is it 45, 60?
It is 45, right?
Okay.
At least 45, okay?
Okay.
And Mrs. St. Martin, if I am saying anything that contradicts what you're saying in class, please tell me because I want to make sure that I am in lockstep with exactly everything that you're teaching in the classroom. Oh, wait, we don't hear you, Mrs. St. Martin. I'm sorry. No. I see your lips moving, but no. Do you have headsets or anything? You're unmuted. Maybe they're not working well. I don't know. No. No. Do you want to leave and come back? Because sometimes that fix it. Or you can do like a sound check. If you test your audio, maybe. Okay, don't hear you still. No. Okay, so she'll leave and come back. Okay, so we'll give her a chance to leave and come back, and then I will pull up the notes for the next chapter while we're waiting for her to come back. So the external eye, we're looking for conjunctivitis. What would a patient say that would make you think that they have conjunctivitis? What would be some of the subjective information?
Maybe itching, burning, irritation, like
Okay,
drainage sometimes.
yes. Okay, absolutely. So they will also possibly say, this morning when I woke up, my eyes were stuck shut, right?
Mm-hmm.
Because of all of the crustiness, right?
Yes.
So, yeah, so those are all signs, everything that you mentioned, those are all signs of, okay, I'm thinking pink eye, and I know that pink eye is extremely contagious, right?
Yes.
So they have to be on those eye ointment drops for at least 24 hours before they can go back to school, work, or interact with other humans.
Right.
Okay. Other conditions of the internal eye that includes cataracts, and so cataracts, like as you're studying for the test, you should know that that's a cloudiness in the lens of the eye. It's usually found more commonly in your geriatric patients, right?
Yes.
And so that could be easily corrected by a surgery. And there's also diabetic retinopathy. And if you're not sure of what a condition is, try to break up the terms, right? Diabetic, okay, this is something that diabetic patients have. They have diabetes.
Mm-hmm.
Retinopathy is something to do with the retina, right?
Yes.
And so we know that our diabetic patients, they are at risk for blindness, right? Because the high levels of sugar in their bloodstream can damage those blood vessels, damage their eyes. So every 6 months, they should be going to get an eye screening. Okay, we have Ms. Harris that has joined us. Welcome, Ms. Harris. How are you? Okay. All right, let's see. We have Ms. Harris that has joined, and your Professor St. Martin has rejoined. All right, let's see if we can get her audio.
Can you hear me now?
Yes, perfection. Yes,
Okay,
thank you.
awesome. I was just saying that I appreciate you mentioning that the book really does need to be read before class because to engage in that material and to be able to have questions is really going to be helpful. It's pretty dry content, unfortunately, but it's something that's our basis, and everything that we do is from that. So I appreciate you reiterating that.
Yes, absolutely. Yes. Because I've been in the classroom, so I know what it's like, and I've been a student too, as we have been, right? So I know some of them are working on time management, finding that time. So looking at these key points is also something else that they could do. We,
Absolutely. They're great.
yeah. Okay, awesome. So we have Ms. Harris. Welcome, Ms. Harris. I just want to make sure that you know how to find these resources from the textbook. So if you have, and you should be able to log into Evolve and go to your textbook and go to student resources. And for student resources, you have key points, you have review questions, and you have video clips, you have next generation case studies. But I really focused on the key points. And
Hmm.
one of the things that you could do is when you pull up those key points, and this is going to buffer for a minute, but I have chapter 10 already here. So those key points are the things that you should be familiar with before you go to class, right? In a perfect world, you read your textbook before you go to class so you can have some questions and have an idea of what's going to be covered. And so I was just quickly going over some of these key points, bringing out some things. And if any of these things don't make sense to you, or you're like, man, I don't remember that from anatomy, just Google real quick a quick video, an interactive video. Okay, show me the anatomy of the eye. So it can kind of be more familiar to you. So when you go to class, you'll be ready to rock and roll, and you can ask your instructor questions, or you can engage with what the instructor is presenting to you. All right, I'm going to pause for a second and go to Ms. Harris to see if there's any questions. I don't hear you.
Hello?
Hello, I hear you now.
Okay, that's Miss Blunt. It's probably showing up under my grandbaby's name, hers.
Oh, okay. Yes, Carolyn. Okay, but that's fine. Okay, that helps me because I was like, that doesn't look like a name from the classroom. But okay. Yes. Do you have
Carolyn.
any questions?
No, I don't. Thank you. I appreciate you doing it for us.
Yes, you're welcome. Okay, and Mrs. St. Martin is also here. She's taking time out for you all. So,
Hi, Miss
okay.
St. Martin.
Hey, Carolyn. I hope you're staying warm.
Okay. Awesome. So, Miss Carolyn, do you know how to get to these textbook resources?
Yes.
Okay, fantastic. All right, well, let's go now to, we're going to go to the mental health because I think that's another topic that, what is that? What chapter is that? Am I passing it? I am. Okay, chapter 7. Okay, so let's talk about these things in chapter 7 and let's go to the key points. Okay, so we'll go to mental health. All right, when we think about mental health, and let's go to Shamika. Shamika, when you think about mental health, what do you think about when in terms of assessment?
I think that we're going to ask open-ended questions about maybe you said what you said what do we ask about mental health?
Yes, or
I'm
what do
sorry,
you
I'm doing
think?
multiple things.
Okay, that's okay. When I say mental health, what comes to mind when we
The
think about assessment?
mind, the
Okay, the
mental.
mind. Okay,
Yes.
okay, so that's good. Okay, Miss Carolyn, what do you think of?
Behaviors.
Behaviors, that's right. Okay, excellent. Okay, so when we think about the mental health assessment, we are looking at the mind, we are looking at behavior, we're looking at the patient's mood, we're looking at their affect, how are they interacting with us, right? So all of this is included. So mental health could sometimes be scary for nurses, right? But guess
Yes.
what? Any patient at any time can become a mental health patient. So health assessment and the mental aspect is extremely important.
Yes.
Yes, and so some of you mentioned that, okay, I'm looking at their behavior. Some of you mentioned communication, and I want to emphasize therapeutic communication, open-ended
Yes.
questions, right?
Yes.
Those are all things that you have to keep in mind. All right, so this is coming right from your Chapter 7 Mental Health Assessment
Thank
Student
you.
Notes. You're welcome. And I'm also, I think you all pretty much know this, but I'm also kind of explaining it for the students that are going to view the recording so they know that, hey, this valuable resource is here. Okay? So mental health is an integral part of an overall health and it's comprehensive. So earlier I mentioned that any patient can become a mental health patient. So here's an example. You have a patient that's a medical surgical patient coming in for an operation of some sort. They have to be NPO for 24 hours before coming for this procedure. So they're also a functioning alcoholic. That means that they have not taken a drink of alcohol within 24 hours. Well, we know as we're looking at mental health, within 24, 48 hours, that patient is probably going to start going through withdrawals, right?
Yes.
They're going to start going through DTs. It may affect their blood pressure. They may have hallucinations, right? They may become combative. So that's why we all have to, as nurses, be aware of mental health and potential mental health issues. Okay, so asking that patient if they drink alcohol, do they use street drugs, right? Those are all important things that could affect their mental health. The way that they handle stress is another portion of their mental health, right? Eating disorders, the medications that they take, that could affect their mental health. So all of this, I want you to view it in a comprehensive way. Okay, so we know that the limbic system, right, is a part of the brain that controls emotions. And those of you that have teenagers or you ever had a teenager or a young person, you know that their limbic system is not fully developed yet. So that's why they may make questionable choices. And you're like, did you think this through? Well, I did, but my limbic system is not quite yet mature. Okay, so
Yes.
so we have to think about that, right? And that's a consideration in case you see that in an NCLEX scenario, right? Especially maybe when you get to mental health class or your PEDS class. Okay, so medications, when we think about medications for mental health disorders, they can cause adverse side effects that may change mood, that may change behavior, that may affect other medications that the patient is taking. So that's why that medication reconciliation is so important, right? What else do I want to say about that? So deviation. So when we talk about deviations from expected findings, here's an example. A patient comes in and they come into the office today. It's 25 degrees outside. They come in the office with Daisy Dukes and a tank top.
Mhm.
Is that a cause for concern?
Yes.
Yes. I would think they're manic.
Yes, I'm like, okay, something's not quite right with this patient because they're not presenting in an appropriate way. Okay. Conversely, if it's 100 degrees outside and a patient comes in a fur coat, right? Like, whoa, this is not matching up. Okay. Another example that of behavior that's not congruent that will kind of make you raise your eyebrows. If I say today is the worst day of my life, my cat died, my dog died, and my husband left me, and then I start to laugh hysterically. Like that's not adding up, right? So my mood, my affect is not matching with what I'm telling you. So those are all like red flags, and you're like, okay, something's going on with this patient. Okay, so some of the questions we have to ask when we're looking at mental health assessment is what kind of relationships do they have? Do they have steady employment? How are they handling their stress? Are they using drugs and alcohol? Now, something that you're going to get into when you get into mental health is the dual diagnosis. Many of our patients have mental health concerns or mental illness, and they are also using substances like alcohol or drugs or street drugs. Okay, so that is a dual diagnosis. So we have to look out for that. Okay, this is talking about depression. Okay, Shamiqua, tell me how we can tell a patient may be depressed. What are some of the signs, symptoms, the cues that we may see?
They may be hold on one second. I know depressed people they may say one thing and may show another. Not always sad or emotions. I know depression may be a lot of different things. Hold on one second. I'm sorry.
Okay.
I'm juggling a couple of things
Okay. No,
here.
no, but you've given us enough. Let's go to Miss Carolyn. Miss Carolyn, tell us, if you have a depressed patient, how could they present to you? What's some of the subjective things that you may hear or see?
Crying, withdrawal,
Avoiding
Okay.
eye
won't be left
contact.
alone.
I'm sorry. Am
Mhm.
I on thing? I'm sorry. I'm muted.
Okay. Okay. So I heard withdrawal, avoiding eye contact.
Yes.
Okay.
With
Yes. Hmm.
oh no, that was it. I'm sorry.
Okay.
May I
That's
add some more?
yes, of course.
Could it be someone that I don't know may seem like they're fine, but they what is it? I read the teariness. They may look like they were crying. They may look disheveled. Like they're not grooming themselves or something.
Yes. Okay. And I think Mrs. St. Martin wants to add to that. Go ahead, ma'am.
Something we saw a lot during COVID, especially for the home health population and that older population, was a lot of withdrawal. All of a sudden, people that were, cognitively intact
Uh huh.
could no longer, they were no longer oriented times four. But once we started coming in to see them and had our psych nurses coming in to see them on a regular basis, it was almost like you watered a plant that was too dry. Like they just came back to life. One thing that's really challenging too is with the medications, many of these medications, you feel horrible, 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 and you need this med to start working right away, and they don't start working for 3 to 6 weeks. So that can also be really frustrating.
Yes, that's true. Okay, that's excellent. Okay. Thank you, Mrs. St. Martin. Anything else you wanted to add for what we've gone over so far? I'll scroll back a little bit.
No, you're
No.
amazing. Thank you.
Yes. Okay. Yeah. No worries. And that's a real, I think, a really important thing to think about, right? What your professor has mentioned. And so this should be part of your assessment. Asking these questions, developing that critical eye. What has changed? We know COVID changed so many things for us. And so when you have a patient that is exhibiting certain behaviors, maybe Mrs. Smith is pushing the call bell every 5 minutes. You can be annoyed with her, right? But don't take it out on her. But instead of the fact that she's pushing the call bell, look at the behavior. Why is the patient behaving in this way? What is that behavior trying to convey to us as nurses so we can meet the need that the patient is trying to convey to us? Okay. Um, the other thing I thought about when Professor St. Martin was mentioning the medications taking such a long time, sometimes those medications don't work. Like the first try of the particular medication is not effective, and they have to wait 2 weeks until they can start another medication. The other thing that I will mention also about the medication is that, okay, there could be certain side effects. There could be side effects like weight gain, sexual dysfunction. So, and sometimes the patients may not understand the significance of the importance, right, of staying on that medication regimen, and they may not want to experience those side effects. So going back to the depressed patient, so all of you mentioned some great things. So is this patient able to carry out their ADLs or activities of daily living? Are they experiencing hypersomnia, sleeping too much, or insomnia, not sleeping enough or not getting restful sleep, not able to stay sleeping? Are they overeating? That can be your depressed patient. Are they not eating enough, right? Are they malnutrition? I love what Shamik said in terms of, okay, they may look disheveled. When you have a depressed patient, they may not even be able to perform basic hygiene, okay? And that's something that you have to think about. They may not be able to answer your questions, so it will be very difficult for them if you give them choices. So you want to communicate with them in a therapeutic way, providing clear, concise information and direction. The other thing with the depressed patient, you have to look out for the high risk of suicide, okay? So, mental health disorders, drug use, alcohol abuse, we have to look at that. So, care of infants and children, drug and alcohol use by the mother should be assessed. And last night we talked about As nurses, we are mandatory reporters of child abuse and elder abuse. We talked about that one episode in the show Good Times where Penny, the character, was burned with an iron, right? We talked about the signs and symptoms we would see with elder abuse, what we would see with child abuse, bruises of unequal healing, spiral fractures, right? Those are all things to think about, and we have to report, okay? Depression in your older adults could be seen, right, or misinterpreted as a manifestation of aging. Now we have to think, why would our geriatric patients become depressed? Well, the loved ones around them are expiring. Maybe they have a loss of independence. Maybe they can't drive anymore. Maybe they have a chronic disorder that they're managing, right? So all of this we have to be able to assess. And I think next week in our lab class we can go over the depression scale, right, for your geriatric patient, because there's a specific geriatric depression scale. Last time we talked about the mini mental status exam. That was more for cognitive kind of concerns. Okay, when we talk about cognitive, let's talk about former President Joe Biden. Love him, respect him. I respect all the presidents of the United States, but let's talk about how his performance, if you saw the news and everything and you saw him addressing the public, what were your thoughts if he was your patient? Either one of you could answer.
I thought that he was very forgetful. He couldn't put his thoughts together.
Okay, so he had difficulty expressing himself. He was forgetful. Okay. Anything else you noticed about him?
He couldn't stay focused.
Okay. Couldn't stay focused. Okay. Did
He
you
appeared to
all?
be like his eyes were closing.
Okay, so he wasn't very alert.
Attentive. Yeah.
Okay. Okay. Yes, all of that. Okay. So I'm trying to find a picture, and his debate with Donald Trump, that one, it just didn't go well. It was very scary to see as a nurse, okay? I can't find a picture to show that to you right away. But he did have like a deer in the headlight kind of look where he was kind of blanking out, like he kind of couldn't process his thoughts, he couldn't express himself, right?
That's what I was gonna say. It seemed
Okay.
like slower processing, like memory lapse. To me, he looked like he either forgot or sometimes looked like he just was always tired to me.
Okay. And, and granted, he's going to be tired because his hours, he's flying, he's got this crazy schedule. It's the most stressful job in the world, probably, right? So he's probably going to be exhausted. But as far as like if he was our patient and we saw him in a clinical setting, we would have some concerns about his speech, his ability to express his thoughts, right? And so when we think about it, I would give him the mini mental status exam, right? And so that would be one of the things that we would be able to do. Okay, let's talk about bipolar disorder. Okay, so let's talk about bipolar disorder because that's one of the things on your list here. So what do you all know about bipolar disorder and how would your patient present? And I'm going to give you an image here. Either one of you.
I know being depressed, sometimes you can have depressive disorders, and sometimes they may last longer as of 2 weeks. I know they may have depression and mania, and sometimes they may go hand in hand, I think.
Okay, very good. So, what's the medication of choice for your patient that has bipolar disorder?
Seroquel.
Seroquel. Okay. I'm also looking for something else though.
What is this? Seroquel.
Night to sleep for sure.
I can't think of.
It starts with an L, the one that I'm looking, because I'm thinking in terms of NCLEX.
L.
I know, I'm
Talked
thinking
about it the
too.
other night with my brother.
You were talking about this with him?
My little brother is bipolar 1. So I brought him up in class and what he went through and the mania and everything that he went through and the meds. So yeah.
Okay, I didn't know that. Okay, so
Wait. Is it lithium?
yes,
Yeah, lithium. Yeah.
lithium. Okay, so you gotta know that medication. You gotta understand that. And I have a picture here of Kanye West, right? Not because I love him. I love him as a human being, right? But because we know that he has come forward and he has bipolar disorder. A lot of times I feel like he is not sticking with his medication regimen.
Mm.
Okay. So, but let's talk about it. I have another image for bipolar, right? And so when you are assessing your patient, they can have these periods of mania. They can have these depressive episodes. Now, we talked about depression, right? Because we're talking about mental health, assessing your mental health patient. Depression, we see this patient, we're really concerned about their nutritional status. We're concerned about things slowing down, them not being able to perform their ADLs. We're concerned about suicide, right? Suicidal ideation and suicidal attempts, okay? So those are the things that we're concerned if they're in the depressive state. The manic state is really something to see, right? And I think when we see Kanye West in the public, he's most of the time in his manic state. So he has these grandiose ideas, and he has the money that he could actually do all these grandiose things, right? Sometimes it becomes a sexual thing with patients, and so we have to teach them, okay, when you're in this manic phase, don't make any contracts, don't purchase anything, no large expenditures, because your judgment is poor. In a clinical setting, you might find a patient that is in another patient's room in a compromising situation. That could be a scenario question. You always want to provide for their dignity and escort them outside of the room if they're doing something with another patient that is not appropriate, right? So, and this patient you'll see like riding a motorcycle 100 miles an hour in the rain, right? So they're making poor choices, okay? So this is what you could see when you're assessing your bipolar patient. Any questions about this one?
I have a question about the lithium because you don't see that much like in the nursing home. You don't see patients coming in on lithium. You used to, but not very. It's very rare now in the nursing home.
The nursing home, I will say, is a different kind of animal. But if you are in a behavioral health unit, you will probably see a lot of lithium carbonate being prescribed for your patients. And with that, you have to, and when you get to med surge, I don't want to go too much on a med surge tangent, but you will see the blood work that goes along with lithium because I'm worried about lithium toxicity. And you will also, what else? What is the other thing?
Elevated lipids.
Okay, say yes. Go ahead, Professor St. Martin.
Oh no, I just remember elevated lipids,
Okay, yes, and
triglycerides, I think.
yes, and you will see that kind of stuff when you get to med surge because, and when you get to pharmacology, lithium is one of those medications that you have to monitor for toxicity. There's like 5 top medications that the NCLEX will test you on. Lithium is one of them. Theophylline is another one. Phenytoin is one.
Yep, Dilantin and glove. What is it?
Digoxin.
Digoxin.
Yes, yeah, I was like, those are the top 5. But yes, so this is like, I know we're getting a little med surgery and a little farm, but this is important because what's the next step when you assess, okay, wow, this patient is bipolar, they're in their manic phase. The other thing I will leave you with before we go back to our study guide, our notes, is when your patient is manic, they are moving around. They might not sleep for 3 days. This patient, I am afraid of malnutrition. I'm afraid of their nutritional status, and I'm afraid for cardiovascular collapse. Okay. We had a patient one time, the nursing students, that was in the manic phase, and he could not sit still long enough for them to get his vital signs. Okay, so I know we always say don't let patients nap during the day, but if you have a manic patient that is taking a nap during the day, if you see it in a question, let this patient sleep because we are afraid of cardiovascular collapse for this patient. Okay, I'm going to pause for a second to see if Professor St. Martin wants to add anything.
Thank you.
Okay, all right, and are there any questions from the class?
No.
Oh,
No, you went over what I kind of needed. And I think the picture for the bipolar is like amazing. And I would say drawing the face of the cranial nerves over and over again and knowing the function and the, what is it? What goes wrong with the function, like what happens to those
mm-hmm.
different body parts that those nerves control. Like I was just going over that last night, which to me the face helped me a little bit more than the flashcards because you know where everything is. So I thought that was really great.
Okay, fantastic. And we are actually in lab. We're going to be doing all of these tests for the cranial nerves. I'm really excited about that. So that's a part of our focused neurological assessment. Okay, let's jump into schizophrenia because schizophrenia is another thing that we see a lot of, right? And that's one of the things on your checklist. So I want to make sure that I address it. So your schizophrenic patient, schizophrenia is more commonly found in males, but it could be in females. And we don't necessarily diagnose patients with schizophrenia until their late teens, early 20s. Okay, and so with schizophrenia, the patient may have these hallucinations. So we have five senses. They can have these hallucinations via their five senses, meaning that they can have tactile hallucinations. They may feel something like bugs crawling on them, but there's really no bugs crawling on them. They may hear voices in their head saying, okay, so and so and so, right? The important thing when you're assessing and working with your schizophrenic patient that is having these hallucinations, an NCLEX concept that you must know is, what are the voices telling you, Mrs. Smith? Okay, so because those voices could be saying, hey, the beautiful flowers outside, there's butterflies, or those voices could be very dark and saying, hey, kill everyone here, chop off their heads, right? So we kind of need to know what those voices are telling the patient. Okay, so they can have visual hallucinations, seeing things that are actually not there. And one of the things that you have to do when you're working with these mental health patients, of course, always be therapeutic, always be de-escalatory, but don't argue with them. So if Mrs. Smith says, I see 10 cats there, they're crawling up the wall. Don't tell Mrs. Smith, there's not cats there, they're not crawling up the wall. So an appropriate response would be, and you see this in your questions, Mrs. Smith, I understand you're seeing something that is scaring you. Can you describe what you're seeing? Right? Or, Mrs. Smith, you're safe here. Take my hand. We are here in the facility. My name is Colleen. I'm going to be your nurse. I'm going to be caring for you today. So you want to practice therapeutic communication, try to reorient them and ground them, right? So that they are coming back to the reality that we are in. But sometimes you have patients that are in a psychotic state that they will not even respond to you. And that is sometimes pretty scary. Okay. The other thing you could see with your schizophrenic patient is that they have these beliefs. They may have things like word salad, neologisms, and neologisms are words that only mean something to them. So there was an episode of SVU. It's like in the beginning of SVU. There was a guy that he was a criminal, but he had a psychotic break and he was worried about his son Tate. And he was like, the Kashistis are coming, the Kashistis are coming. And this is like an old episode, so I don't know if anybody has seen that episode, but he was talking about the Kashistis. And like, Benson and the other guy, there was like, what are the Kashistis? But that was a neologism because that only meant something to him, right? Because he was schizophrenic. So you have to look at things like word salad. They're going to be saying words and it's not going to be a flowing sentence, right? They may have thought intrusion. People are putting things into their head. What does that look like? Well, I'm watching TV and the guy at CNN is talking directly to me. He's telling me to do something, right? So those are the things that you can see in your patient with schizophrenia. So if you see someone that is responding to an internal dialogue, right? A lot of times driving around Hampton Roads, you'll see them. They're standing outside. I see them all the time, right? They're standing outside. They're talking to themselves. They may be swinging. They may be dancing, right? But that, I feel, is a patient that has schizophrenia. Okay. I'm going to pause for a second because I know this picture was a lot to take in to see if there's any questions.
No, I don't have any. I actually, my grandkids' mother had a schizophrenia episode where she thought that everybody was trying to kill her, and she would keep calling 911 and saying, "I don't want to die, I don't want to die," and then they couldn't calm her down to get her in the ambulance. So eventually, we took her to the hospital, and they had a hostage situation going on. So they actually had to restrain her and medicate her in order to get her calmed down enough so the doctor could see her. So then we wound up getting her committed for a few days.
Wow. Okay. Wow. So that's pretty interesting. I'm sorry that you had to go through that, but that is a great example, right? So this would be like a paranoid schizophrenic, and so this they will have these things, these feelings of, okay, someone's trying to get me, someone's trying to poison me. I've seen them in the clinical setting where it's like, okay, they will only eat packaged foods because they're like, my family's trying to kill me, right? So yeah, let's go to depression. So we talked about depression a lot. Let's talk about delirium and dementia. Okay, so big NCLEX kind of concepts that you gotta know, right? And assessing the patient. A patient that has delirium, this patient can be restored to their previous condition. Okay, dementia is progressive, it's gradual, right? But the patient will not be restored to their previous condition. So you could have test questions about like the dementia patient. The family may say, when is grandma going to come back home? When is grandma going to remember me? Well, unfortunately, grandma's not going to remember you, right? So there's actual changes in the brain. And I don't think for a health assessment, I don't know if you go into the details of the different kind, but definitely for med-surg, you're going to go into that. Okay, Professor Seymour, did you want to add anything to that?
No, just I don't think we go into the different variations of dementia, like Lewy body and everything.
Okay, awesome. But you will see that for med-surg, so it's coming. Okay, but one thing that I also want to say with your mental health patients, besides therapeutic communication, but safety is going to be the most important. So when you're answering these test questions, you want to keep the patient safe. Okay, so if the choice is not going to keep the patient safe, that's not a good answer choice to select. All right, so we talked a little bit about dementia. Let's go to delirium. So delirium, there's many different reasons why a patient could be in a delirious state. So, but delirium is sudden. Okay, what is the underlying condition that is causing this patient to become suddenly confused? It could be lack of oxygenation, low blood sugar, right? It could be sepsis, right? It could be a reaction to medication, right? So we have to figure out all of these things. So if you see a test question, if you have a case study and it has this patient, the new patient, that you have a new medication, right? They're suddenly delirious. We have to get to the underlying cause. Once we treat the underlying cause, the patient can then resume life as they were before. Okay, but delirium versus dementia, a high yield NCLEX question that sometimes gets confused. Okay. So delirium, dementia, anxiety, and OCD is at the end. Okay, so let's talk about OCD because that is an important one. What can y'all tell me about OCD? How would the patient present?
They like things organized, and they constantly repeat the same behavior over and over.
Okay, so you're on the right track. And so I will tell you, not all patients that have OCD like to see things organized, right? Because I know in society we say, oh, I'm OCD, I have to be really neat. Well, that's not necessarily a mental health issue, right? Having things organized. With true OCD, this is affecting their ADLs, their ability to carry out their daily activities of living. So you all probably seen hoarders, right?
Yes.
That is actually OCD, okay? And it's not the OCD that we normally think of, like someone that's really neat and organized, everything's shiny and straight and dust free. This is the other end of it, and that is the patient, when they have OCD, is obsessive compulsive disorder. So they have these thoughts, okay, these obsessions. I'm so bad, I've made a mistake, you're just an evil person, you're dirty, you're going to get sick. And so their internal dialogue is repeating these thoughts, right? And those are the obsessions. And the compulsions are what they do to alleviate those fears, those anxieties. Okay, I'm a dirty person. I'm going to wash my hands 15 times, right? Every hour, right? So that's what we're talking about when we think about obsessive compulsive disorder. And this becomes an issue when it affects their ability to carry out their ADLs. So what do I mean? If the person is late for work every day, if they're late for class, if they can't function, they're not taking care of their family, their responsibility, then this is when this OCD becomes an issue for them. Okay. All right. So I'm going to stop sharing and pause for any questions because we have gone over the highlights of those two chapters. Any questions?
Not at the
No.
moment, but that helped me a lot. Thank you.
You're welcome.
Yes.
Okay.
Thank you.
Okay, I am going to ask Professor St. Martin if she wants to add anything.
No, thank you.
Okay. So I know we're almost at the 7 o'clock hour. I do have a Kahoot, but I could just post it and you all could take it on your own time. And that's just a review of pretty much everything that we did last night. Would that be acceptable to you ladies, Ms. Thompson and Mrs. Blunt?
Yes, ma'am.
Okay, fantastic. Okay, I'm going to stop recording.